One of the questions that I'm always interested in is like, what exactly is leaking out of the blood and into the brain that can promote seizures? And so there's, it's such an obvious question, but there are so many different proteins in our blood that just should never be near neural tissue because it can cause hyperexcitability.
Welcome to Epilepsy Sparks Insights. I'm your host, Torie Robinson, and here we talk with specialist clinicians and researchers to spark improved understanding of the epilepsies worldwide. If you're new here, please subscribe so that you don't miss future conversations, and let's get into today's episode. Today I'm joined by Dr. Claire Behan from Trinity College Dublin and Dr. Chris Greene from RCSI, who are here to share their fascinating research into the blood-brain barrier and epilepsy, including how surgery may not only stop seizures but also help the brain repair itself. Now, why did you start your research into blood-brain barrier research when it comes to epilepsy? And what is the blood-brain barrier?
This is a question that honestly goes back over 100 years. The blood-brain barrier is like, your airport security. It's important for controlling what can go in and out of an airport, but in this case, it's important for controlling what moves in and out of the brain. So people that have their correct passport and their boarding pass can move in, and then they go through security screening to make sure there's nothing dangerous in their bag. And that's exactly what the blood-brain barrier does. It controls what moves in and out of the brain. And so it's formed by the blood vessels in our brains. And we were interested in studying it in the context of epilepsy because it's been shown to be dysfunctional across many different neurological disorders. And so back in the 1960s to 1970s, when clinicians were trying to devise experiments that transiently opened up this barrier so that we could get more drugs into the brain to treat brain cancer, for example, they saw that when you briefly opened it up, it could actually cause seizures in these patients. So back in the 60s and 70s, we had the clinical study and the clinical validation already that just by opening this blood-brain barrier, we could actually cause seizures in people. And so that's why we were interested in studying, well, what exactly is happening to this barrier? What is changing that's causing these seizures and causing these hyperexcitability within the brain?
So tell us, Claire, what did your research involve? What did you focus on?
So we recruited patients who had temporal lobe epilepsy, and we want to identify those who we felt would have a dysfunctional blood-brain barrier. So these were patients who were epilepsy surgery candidates. In particular, they had a temporal lobe epilepsy and they were going for epilepsy surgery. And often these are patients who have tried multiple anti-seizure medications, and they're really at the end of the road when it comes to options for improving their seizure frequency and improving generally their quality of life. So we recruited these patients, 7 in total. So a small study, but it really allows us to, give some proof of concept to the idea. And the patients needed to have an imaging done before their surgery and then imaging done afterwards. And the idea being that we were going to be able to compare their pre and post imaging in order to make some observations about that.
And what type of imaging was this?
So we used what's called DICE imaging, so it's dynamic contrast enhanced MRI. And so to understand this, we need to understand exactly what the blood-brain barrier is. So look, back in the end of the 19th century, there was this bacteriologist by the name of Paul Ehrlich who was designing some dyes that could tell him how much oxygen was being consumed by different organs throughout the body. He injected one of these dyes and he saw that it lit up everywhere in the body except for the brain. And so this indicated that there's potentially some sort of, at first he thought that it was just the dye didn't have any activity within the brain. One of his students then, Edwin Goldman, a few years later, actually reversed the experiment and injected it directly into the brain. And this is where he saw that it lit up the brain then, as well as the spinal cord, but it didn't light up anywhere else in the body. So there's some sort of compartmentalization. And that's exactly how we do our imaging approaches. We can inject a dye, in this case, a contrast agent called gadolinium. We can look at sequential MRI scans, so at images of the brain before and after we inject this. And then we can quantify where and to what extent this dye is going across the blood-brain barrier. Because in a healthy person that has an intact blood-brain barrier, it's going to stay within the vessels. And so in a dysfunctional case, like in a person with drug-resistant epilepsy who has recurrent seizures, there's going to be hotspots within the brain where we can see this leaking out and into the brain tissue. And that's exactly what we can quantify.
Okay, just on the side, in theory, would that, if you've got a bit of a stuffed up blood-brain barrier, Could that not make absorption of anti-seizure medications even better?
That's a very important point. So it harks back to what exactly is going on with these blood vessels that may be actually contributing to the development of epilepsy. And so what is happening is that they're essentially undergoing an identity crisis. They don't have the normal properties that these blood vessels in the brain should have. And so one of the key properties is their ability to transport molecules from the blood and into the brain. But because of these unique properties, at present, of the 7,000 drugs that are available, over 95% of them can't actually cross the blood-brain barrier. And so lots of the anti-seizure medications that are available are substrates for a certain receptor that's present on these brain endothelial cells called P-glycoprotein. So these are multi-drug transporters. And so when an anti-seizure medication goes into one of these cells, it's immediately pumped back out. And so what we're seeing from animal research is that these receptors get hugely upregulated in cases of drug-resistant epilepsy in these blood vessels. So they're dysfunctional because they're expressing too much of these, but they're leaky, and it's almost like a non-specific leakiness where you have proteins that are normally in the blood can seep in through the endothelial cells, but at the same time, you're getting much more and much greater expression of these drug metabolizing enzymes and transporters. So that's also one of the reasons that we suspect that anti-seizure medications are inadequate in as many as 30% of people with temporal lobe epilepsy.
You're making me think of food, like how you can eat too much and you can eat too little. You've got to have just the right amount to not be unwell to a degree. And I guess that's kind of similar in terms of what is allowed through the blood-brain barrier. You can have too much of one thing, one molecule, or you can have too little of it.
Food is the perfect example because we don't produce energy in the brain. We get all of our energy from what we eat. So if you think about having a sandwich at lunch, 25% of the energy of that in the form of glucose has to go to the brain because it's such a hungry organ. It consumes so much glucose, but it can't just move into the brain. If it done that, it would be catastrophic. There would be way too much activity and it would be horrendous seizures, and it would just be catastrophic for the homeostasis for how our brains function. So instead, we have specific transporters for glucose. So it's one called the GLUT1 transporter. And you'll probably know from people that have GLUT1 deficiency syndrome, they can't get enough glucose into their brain because they have a deficiency in this transporter. And what do they get? They have seizures and epilepsy.
Gosh, we are such sensitive animals, primates, aren't we?
But at the same time, it shows how adaptable we are, because if we switch to an alternative energy source in the case of people with GLUT1 deficiency syndrome, like a ketogenic diet, we can have an alternative fuel source that can get into the brain, and it's very beneficial for those patients as well.
Tell us about how surgery helps with all of this, though. So say you've got a bit of a stuffed up BBB. What difference does epilepsy surgery make to that?
The patients in our study who had their epilepsy surgery and they had their temporal lobectomy, 5 of those patients became seizure-free. And so we are assuming that we've removed the epileptogenic part of the brain.
What happened to the other 2? Do you know? Or they partially reduced seizures or just?
They continued to have seizures. One of them is listed for a secondary follow-up procedure, and the other one continued. The other one had that kind of, sometimes that you observe this honeymoon period where their seizures reduced and then they restarted again. And in those 2 patients, their blood-brain barrier, when we scanned them after the procedure, they continued to have a dysfunctional blood-brain barrier. So in the 5 patients who had their seizures resolved, their blood-brain barrier looked good, looked nice and healthy and restored. So essentially healed. But in our 2 patients who continued to have seizures, we didn't observe that. They still had that dysregulated or poor blood-brain barrier, leaky blood-brain barrier, lots of ways that we describe this, which was very interesting.
It's important in this particular group of patients, they were all having different types of seizures. So the type of seizure is going to influence the surgical outcome as well. The number of seizures that they're having as well, because what we're seeing when we look at these pre-surgery scans, that there's a huge variability in the degree of the dysfunction of this barrier. And so for an individual that's having a focal to bilateral generalized seizure, it's going to encompass their whole brain and not just their temporal lobe. So that begs the question, how can a surgical removal of a very specific brain region ultimately affect distant regions of our brain as well? And I'm kind of just spitballing ideas here, but it points to the idea that the blood vessels in our brain retain an inherent plasticity. They are injured, but they can resolve from this injury. They can recover their normal natural functions. And I expect that this is what we're seeing in this particular case. And so for individuals that are having recurrent seizures, whether it's a case of it was a failure of surgery, we don't know. Maybe we didn't get the entire epileptogenic zone. Or maybe there's a continuing dysfunction of the blood vessels that's having a seizure-promoting effect that's sustaining their epilepsy. And we're seeing this when we go back to our animal models. So one of the questions that I'm always interested in is what exactly is leaking out of the blood and into the brain that can promote seizures? Yeah. And so there's, it's such an obvious question, but there are so many different proteins in our blood that just should never be near neural tissue because it can cause hyperexcitability. And there's been lots of studies actually done from resected tissue from patients that have underwent these surgery. And then they've screened these tissue samples to see, what was normally in the blood and seeping out. And there's a ton of different proteins. But one of them in particular that's really interesting is albumin. It's our most abundant protein in our entire blood. But when it seeps out of blood into our brain, it can be taken up by these other cells called astrocytes. Now, they're really important for providing structural support to our blood vessels, but they're like hoovers. They mop up extracellular glutamate and potassium, and they maintain buffering. Too much glutamate, the major excitatory neurotransmitter in the brain, what's going to happen? It's going to cause hyperexcitability, and it's going to prime an environment where seizures are like to recur. And so one of these proteins, albumin, can be taken up by these astrocytes, and it completely changes their function. So they can no longer hoover up all this excess potassium and glutamate. And so it's priming this environment. And it's also causing dysfunction of the blood-brain barrier at the same time.
Outrageously complex. And so what are the next stages when it comes to the results we have from this study? Because the results look very, very interesting, but what do we do next?
For me, my line of research, it's we're always interested in asking questions like, do changes in blood-brain barrier function contribute to disease? It's well established now that this is the case. Can we measure changes in blood-brain barrier integrity as a prognostic marker for disease and for recurrence? And I think that's where we need to go now with much larger clinical studies to see if we can look at patterns of blood-brain barrier disruption on these scans to ultimately predict the likelihood of someone having a successful surgery outcome, or as long-term biomarkers for understanding their treatment journey as well. But then finally, can we actually target these blood vessels? Can we design some innovative therapies that can stabilize their integrity? And this is actually something that we've already done in animal models. Back in 2022, we published a paper where we showed that there is one particular protein, one of these tight junctions proteins, that actually seals the cells together in these blood vessels.
Wow.
So it's called Claudin 5. And so we went back to our genetic tools and we depleted it in the blood-brain barrier cells, so in our endothelial cells in mice. And when we remove it, what do we think happens? The mice develop spontaneous recurrent seizures because they had an open blood-brain barrier. So this is our kind of, our proof of principle that you can remove just one component of the barrier, you can cause epilepsy in mice. And so what happens when we restore it? The seizures went away. And so we're now kind of at a stage where we can test in our preclinical animal models, okay, are there any specific barrier restoring therapies that we can potentially trial that could be disease modifying in epilepsy?
Or I would say ideally, rather than treating the issue, perhaps identifying when the issue may be likely to occur so that people don't actually end up having seizures.
In the clinic, this is really exciting. And I think, that part of the prognostic piece, when you're having that conversation with someone about surgery, it's a big deal. There's lots to consider to be able to give a little bit more certainty. Well, you have this type of blood-brain barrier, so you're more likely to have a successful surgery versus maybe this isn't the right route. So maybe we need to consider other options. So that part is very exciting. And potentially being able to identify a particular blood-brain barrier pre-seizure, that early, that would kind of revolutionize what we do and have very different outcomes for patients.
That'd be amazing.
A precision therapy, wow, here you go. This is, we're not going to just dampen down everything that's happening with these medications that potentially have lots of side effects. And instead, we're going to look specifically at you and what we can do to target your issue individually. So, and lots happening in that space as well, but it's exciting.
Thank you so much, Claire and Chris, for shedding light on how the blood-brain barrier is involved in epilepsy and how further research could help guide future treatments and surgical decisions. And thank you for watching Epilepsy Sparks Insights. If you found this conversation helpful, please give it a like and subscribe and hit the bell so that you're notified when new episodes drop. I'd also love to hear your thoughts or experiences in the comments below. I do read them. See you next time.